and welcome.
Thank you very much. Yeah, and before I start, I just want to thank the committee for giving me the opportunity to be here and to visit this beautiful country. And I've been to Istanbul before, and it's definitely ranked on top 2 of my favorite city in the world. And now I have the opportunity to explore more places in Turkey. So yeah, I'm not going to blame you on not able to pronounce Saskatchewan, because President Obama couldn't. So that's all right. Okay, so I will keep my talk relatively short because I have a privilege to give more explanations on the 20th, if anybody interested in that. Okay, so I do not have any conflict of interest to declare, and all the research are not funded by any of the equipment providers. So overall, what I want to do is I want to really introduce a new emerging equipment which may give us a different angle to treat depression and also other neuropsychiatric disorders, and then to see what so far the evidence we have. Even this evidence is really limited, but it's really opened the door that I think will eventually benefit our patient. Okay, we all know that depression is the number one burden for the world, and that's why we all here, and we try to do things to help and to reduce this disability. Yeah, and okay, so I'm not going to introduce this one because I know most of you are clinicians, so I'll just skip it. But we know that the treatment part, and from Canadian treatment guidelines, we recommended the mild to moderate patient try the psychotherapy first, and then if it's not working, and then medication might be a choice, and so that's kind of tier up or step up care. However, the challenge we have is almost 50% of our patients, that's even we try the first medication, it won't work. And even that's another 30% of them won't even respond to 2 or more medications. That's what we call treatment-resistant depression. So that causes a huge trouble for clinicians to not able to bring patients back to their normal life. And the lingering problems causing very, very bad consequences, such as suicide, and such as lose their work, lose their ability to provide the support to the families. So that's why it's a big challenge to get there. So even for the patient who responds to the treatment, there's also some other important things we have to consider. First is it takes a few weeks to actually kick in for most patients with medications. I don't think that any of us will expect that the second day, the third day, they will get better. If they get better by that way, and we highly doubt they have a major depressive disorder. And another important thing that used to be undervalued or underestimated is a cognitive impairment. Most people think depression or bipolar disorders, schizophrenia, they all have their distinctive features like depressive symptoms, mania, or psychotic symptoms. But underlying, there's a very big component is a cognitive impairment. That's actually the main cause for them to become disabled. They could not really go back to the work even when they have a remission. So again, other things, I don't know what's the attitude here in Turkey and in Canada, especially in our indigenous population. There's quite a big resistance to take medications. And even for the well-educated groups that I'm treating as a university student, they associate the treatment with stigma. They do not really want to be labeled as a patient need to take antidepressant. So that's also caused a very big uncompliance with the treatment. And further down, children and adolescents, and because of regulation, that we have less available medications and take longer time to get them approved for this population. and our seniors who have multiple medical comorbidities, that's also limited our treatment. So altogether, and I wasn't even mentioned about other medical conditions that have high association with depression. They all limited our options for the medication, which has been not doing their good job. So what can we do? So for Canadian Psychiatry Association, we provide a guideline to see if medication failed, what can we do next? So on the list, there are some options that we were thinking. I think that's probably very much the same as here. And we spend a lot of time talking about TMS, so I'm not going to spend time on it. And another option is ECT, the electronic conversion therapy. Why we not put this one as the first line is because it's very expensive. We need a full team and a full unit to do that, and to make sure that patients recover properly. So, and the other speakers mentioned about the DBT, and DBT is invasive, and also the result is inconsistent. So that's why it leaves us a big challenge, but also opportunity to think out of the box. What can we do? So this is just a brief summary of what Canadians are told, or Canadian physicians told what to do, how we can choose from one to another. Okay, so this is a TMS, and I think everybody talk about it, and there's so many different versions of TMS that has been proved by FDA or by Health Canada and by other countries. But why we do not stop here is because, because first of all, it works, but it's not necessarily works for everybody. Second, it's expensive. So why I mentioned expensive or money all the time is because I come from Canada. We do not have that much money, but we try to take care of everybody, not like, so that's how we try to say, we're on that part slightly better than US, but actually it's not. It's because our patient, after they seen and diagnosed with depression, it takes 6 months for them to come to see me as a psychiatrist. So 6 months, anything could happen. So that's why, because we do not have money to cover everybody at that way. So we desperately need something cheaper, faster, and more affordable. And so that's why this one is super expensive, and also need a technician to work on that. And 8 or probably 10 or 8 or more patient can